Good afternoon, everybody, and welcome to the second of our Grand Round series dedicated to the COVID epidemic. There is no question that the current crisis is in historical perspective, needs a look back and a look forward, which is the title of our Grand Rounds today. I'm happy that Professor Jim Sherry, our Professor of Migrant and Global Health, will be moderating this session. And we are also very pleased that our Center for Migrant and Global Health is sponsoring this important session. Today's forum will address several issues and questions, including what should a sustained response to an unfolding crisis look like? Where have we done things well in the past, and what might be different, positive or negative this time? The participants in today's session will include Professor Dr. Michael Merson, Professor Bruce Lee from the School of Public Health, and our senior scholar at the School of Public Health, Dr. Kathleen Cravero. It gives me tremendous pleasure to introduce Professor Dr. Michael Merson, who is the former director of the WHO Global Program on AIDS. He is the Wolfgang Drocklich Professor of Global Health at Duke University and the founding director of the SingHealth Duke NUS Global Health Institute. He has written widely on global health issues, including co-authoring the AIDS pandemic, Searching for a Global Response. His most recent opinion piece, The Dangerous Fallout from Cutting US Funding for the WHO, was in the Washington Post and got a very broad and enthusiastic audience, including myself. He also has served in advisory capacities for many organizations, including UNAIDS, WHO, the World Bank, and the Bill and Melinda Gates Foundation. It is my distinct pleasure to have Professor Dr. Michael Merson in this important forum, and please allow me to give him the podium for the first presentation today. Mike, it's yours.
Okay, thank you, Ayman. It's a great pleasure to be with you. I hope my screen is okay and you're let me know if I need to make any adjustments. I'm sorry I'm not with you, although I'm only a few blocks from the school. I just want to say ironically that to be with you today talking about this with two colleagues who I worked with quite closely in the almost 25 years ago, more than 25 years ago, Jim Sherry and Kathleen Cravero. So it's wonderful to be with them after so many years. I guess Jim and I talked, and what I might do is say a little bit about where I think the pandemic is going and what my concerns are and what we can learn from the past, and what we might think about learning from the past about the future. The numbers are numbing when we look at the seriousness of where we are today. So numbing, I think the press sometimes doesn't catch how serious this pandemic is. About 80% of the cases so far have been in Europe and the United States, only 3% in China. And I think we've been struck by how fast the disease is spreading and the fact that we're coping with a respiratory infection with asymptomatic spread. And this virus seems right now to find all our blind spots. It has a very distinct clinical presentation, but also has some unusual features, as we have seen right here in New York, with the large number of people dying from pneumonia and blood clots and heart disease. But I think the real interesting question is, where is it going to go next? And I think there are two concerns that you hear and you think about, one more than the other. We hear a lot on our media about the second wave and a great concern about the second wave in places that have already had a serious first wave. And we know that in the Asian countries, they have faced a second wave already in some of them. A lot of it due to returning citizens from abroad. In Singapore, where I work quite a bit, it's also due to infection in large amount of infection in foreign workers. And here in this country, this has been a real challenge because we don't have testing, and this has had unfortunate political implications. But the second concern, which hasn't gotten very much attention, but I think will, I hope, is when this pandemic spreads much more to lower and middle income countries. Countries that have fragile health systems, insufficient amount of PPE, staff, and equipment in hospitals, limited supply of tests, high disease burden, high density, living conditions, lack of this water and soap, and tiny financial reserves in families and countries. It's still early days in these countries. Africa has about 0.7% of all the cases reported. Asia outside China, 3%, Latin America, 4.3%. We saw a 43% jump last week in Africa, but it's hard to know what to make of these numbers because testing is not being done very much. But what is interesting and what we've seen in many of these lower and some middle income countries is they went right to mitigation. They didn't even try containment. I think they saw what happened in China and the United States and felt that they couldn't do containment. But the question they're all going to face is what will happen as they try to lift their current strategies of mitigation, their lockdowns. What are they going to face then in terms of transmission? The same questions we're asking here in the States. The only real, so far, detailed projection I've seen of how many cases will occur and deaths in the low and middle income countries came from Oxford a few weeks ago, and it projected under the best scenario, 1.3 million COVID deaths. Now then, we also have to be concerned about what we would call the indirect, maybe we call that term, or the deaths that are going to occur not due to COVID, but due to other health problems, which are not going to get the attention that they need and have gotten because of COVID. There's a talk of over 100 million children not getting vaccinated against measles. Polio eradication programs have more or less stopped. AIDS, TB, and malaria programs are under great stress to continue their work. There's great concern about malnutrition due to food insecurities, and on and on. Now, we hope for a drug to reduce mortality, and we hope for a vaccine, maybe in 1 or 2 years, but we can't count on them in the immediate future to help the low and middle income countries. I don't mean to project a doom and gloom scenario, but we need to really be concerned about what's coming. And that gets to the second point, and that is, what have we learned from previous pandemics that have affected these countries? Now, over the last couple of decades, we've had a whole number of pandemics and epidemics. Of course, we've had HIV, which has been the most serious, 75 million cases and 32 million deaths over 40 years. We've also had MERS and SARS and H1N1. I don't have time to talk about all of them, but let me just focus for the moment on AIDS, since it's the one I know and the one that's been most serious. What have we learned from that? Well, of course, AIDS had some differences from COVID. It was transmitted through bodily fluids, sex, and drug use, blood, and maternal-child transmission. It spread more slowly. It was really 2 pandemics, the silent pandemic of HIV, followed by 10 years later by the real-life pandemic of AIDS. It mostly affected younger people, and before the advent of drugs was always fatal. And it took 2 years to identify the causative agent, another 2 years to come up with a diagnostic test. We've done that in a month when it comes to COVID. There are similarities, and they're interesting. Both initially caused fear. In the case of AIDS, because it was assumed to be fatal. In the case of COVID, because of its rapid spread and mortality in vulnerable groups. And in both cases, because they were caused by a new virus that we had no known immunity or treatment. For both, treatment has been difficult, requiring changes in behavior, which do not come easy. For both, there has been blatant discrimination against gay men and AIDS, against Asians, and more recently, even against African Americans and Latinos in the case of COVID. In both cases, our government was in denial and slow to react to the disease. And when it did, one of its first actions was to blame the outsider and to impose travel bans. And finally, in both cases, it is the poor who have or will face the greatest vulnerability to infection and disease. So if we look back and we ask ourselves, what happened in the AIDS response? Well, it took 20 years to really mount what I would call a sufficient response. It took 20 years to get strong leadership and trust at the level of national governments, to get the kind of community response that was critical, because after all, we learned in AIDS that community groups know how to best to reach populations and those with the greatest need. It took that long to get a truly multi-sectoral response to deal with the disease itself and its consequences. We took a while to get to real global cooperation to attack what was a global challenge. Science made a huge difference. It took 15 years to have life-saving treatment, but when it arrived, it relieved AIDS as a death sentence and accelerated greatly the global response. We learned in AIDS, as we had in other pandemics, that vulnerabilities matter, that the rights of the poor and racial ethnic minorities are essential to addressing a pandemic. And we learned that health systems matter to deliver, in the case of AIDS, drugs, but they're certainly going to be vital for COVID for testing, contact tracing, and quarantine. So taking all that, now where do we move? How do we move forward? And I put some ideas out that maybe other members of the panel will react to, or the audience, on where do we go from here? Well, on the domestic side, I mean, there's a lot of, you've had talks about this, and it's been a lot of discussion. I'll just say simply that in this country, we certainly need the obvious, which is a national, long-term, and unified response. We're going to be in this for a while, a response that we all trust. I think historians are going to look back at amazement, just amazement, how divided our country has been with regard to our national response. One would think that now more than 40,000 deaths, and there will be more, in a 2-month period, would bring blue and red states together, but this has not happened. It's not too late, though it's hard to be optimistic, but hopefully at least at state and local levels, and with strong leadership and involvement of community groups, and very importantly, the private sector, we can still accomplish a great deal. Strategically, we are faced with the challenge of opening up our economy and everyday life in a way that does not lead to an emergence of new waves of infection. And for that, we need testing and contact tracing. And then if we need to, more aggressive ways of stopping the spread of new infections. The exciting thing about that, I think, if there's a silver lining, we have a chance now, in those of us working in public health, to get a large, hopefully larger commitment to strengthening the public health infrastructure at state and local levels, a rare opportunity to really advocate for this support, and calling attention to the enormous health disparities in our population. We're going to have to bring many sectors in government and society along with us. I think I hope most people would agree with that. the more challenging question for me now is, what do we do at a global level? I think it's fair to say that so far, countries have focused mostly on their own problems. I'm thinking in particular China, the United States, and the European countries. And unfortunately, in the case of China and the United States, they've responded in very competitive ways. So I think we need three things at least. We need a platform to share knowledge and experience on a day-to-day basis and provide guidance on best practices. The obvious place for this is WHO. And I will simply say that this is just not the time to focus on the organization's weaknesses, but rather to provide it the support that it needs to provide this platform. Secondly, we need a global platform for our research efforts. We have over 150 clinical trials underway, over 100 vaccine candidates under development, much confusion about diagnostic tests, and yet time is of the essence. And so we really need coordination and open sharing of information. Now, this is happening on a number of fronts already, I'm pleased to say, particularly with regard to vaccines. Here, we have to plan our trials carefully and in unison and think way in advance about manufacturing and distribution challenges. And then the third area, which is perhaps the more difficult one, is to think about is whether we need a mechanism to support the public health efforts of low and middle income countries where the impact of this pandemic is going to be most severe. I think we need a concerted and coordinated effort by the UN family, by the World Bank and IMF, the bilateral agencies, foundations, and the private sector. Some type of multilateral forum, which who knows might even revive again multilateralism. Now, there's been some hope. Many of you probably know the Global Fund announced this week that you can program its funds for COVID, some of its funds. Gavi has responded in a similar way, so has the World Bank. The US has only pledged $500 million in assistance through AID, which is far from sufficient. We must contribute more if the Congress will debate it, and perhaps use our PEPFAR platform for helping countries. In the case of AIDS, as Kathleen and Jim know well, we established a new UN agency, UNAIDS, as such a global mechanism. And we don't have time, I don't think we have time for this now. And so the question is, in this acute situation, do we use existing platforms? What do we do to bring a global response that is required to help the low and middle income countries avoid what could be, as projected by the Oxford Group, many deaths. I would just conclude by saying that COVID has shown us that we are really a common humanity when it comes to health. It certainly changed the way people around the world already changed the way people think about health, as did AIDS, particularly the interdependency of our health. And my hope is that it will now bring about a major rethinking about how to make the world safe from pandemics. A realization that unless all countries are healthy, no country is going to be safe from the spread of this disease. Thank you, Ayman.
Thank you, Mike, and thanks for your discipline to time, which is quite amazing and laudatory. So I thank you for that. So a couple of questions before we move on, but you know, the first, you alluded to it, but I'd be remiss if I didn't bring you back to your what Ayman mentioned as we started, your recent editorial in the Washington Post, and your remark about and I quite rightly that we don't have time to build new things right now. We've got to make the existing things work. And could you spend another minute or so on what that means with respect to WHO, what that means with respect to supporting it right now, getting it the support it needs to do what is a fairly monumental task.
Okay, I think we know that WHO, without its going into depth about its problems, does some things well. It is right now a lifeline for countries on information about the virus, about how it's spread. We're getting new knowledge almost every day about the disease and what works and doesn't work. Look at the turnaround recently on masks, which came about because of the rapid information that was retrieved from China and then spread around the world. So WHO has that important function. And it's looked on still as a main source of information in most low and middle income countries. It is doing its best to provide advice on containment strategies and treatment strategies. It is providing what it can in the way of equipment and supplies. And we need that. I mean, that and to cut that right now, it's I'll be kind in my word. It just makes no sense. And if a country is upset with WHO, we can debate whether it should or should not be upset with WHO about its relationship with China. I personally think when you look at the facts, WHO reacted in a very reasonable way. There may be issues regarding China, but not necessarily WHO's fault. So I think, Jim, that we should do everything we can to be sure the U.S. government does not cut back its funding. But then you raise a second issue, and it was at the end of my remarks. And it's a similar issue we faced with AIDS, if I may say, in the early part of that pandemic. And that is that these countries need billions of dollars, all told. To help with their programs. They need debt relief. They need the IMF to come in with debt relief. This needs a global response. And probably WHO, as was debated in AIDS, probably can't do that on its own. And so the question is how to get that response. UNAIDS, as you know, struggled in the beginning. Then it was faced with PEPFAR and the Global Fund. And so we wound up having a number of major efforts, and WHO couldn't quite figure out where it fit for a while. So I think the issue is, one, we need WHO to do what it does well, and we need to support it and give whatever support it needs for those actions. But these larger questions, they need a forum, I think, to be addressed. The Global Fund is such a major supporter of countries now, Gavi, UNICEF, we can name others that play a key role right now, not just in COVID, but in all health problems. So that, to me, Jim, is a question that I think needs to be addressed. I know the G20 has tried to do that, but I don't think in its initial effort it got very far.
It's worth, as a part, I thought you might mention this, but I'll just tag in there the earlier on that there were many WHO responses where the boots on the ground might have come from very often the U.S. Centers for Disease Control. It's just that to operate in a particular country, they were not going to allow an American group to come in, but they would happily allow a WHO group in, and of course they absolutely knew what institution or institutions they were from, but they were there with a bona fide, and that made all the difference in terms of governments opening up their interest. That it comes to this related question, Mike. Would you again? It's come up in different ways, and I don't want to just fan the flames of politics right now, but are we seeing some element here in terms of the importance and the limitations of international science, and the role of an institution like WHO and the international societies, for that matter, in terms of the retaining that age-old value of taking truth to power? Are you worried in any way as you watch yet another epidemic unfold that basic principle is eroding in any way, or are there things we should be doing to strengthen that?
You mean around the science?
Around the science and around not being able to, in the absence of, authoritative institutions, or having the authoritative institutions withdrawn in that everything is science, everything is a fact, everything is a new drug, everything is a new approach.
So I think WHO has stepped up and is overseeing clinical trials of 4 drugs, and had a big meeting where it brought together leading scientists. But I think it can become a forum for convening scientists. That it can do. In terms of, though, the development of new drugs and the development of new vaccines, I think certainly NIH in the US is going to be a major player, as are some other institutions in China and in Europe. I don't think, Jim, there's going to be a single agency that is going to coordinate the development of a vaccine. I think but WHO can provide forums for discussion of the various leaders in the different parts of the world. I think with regard to the drugs, this is pharma's work. Thousands of compounds are being screened. And I think we're going to see here, whatever breakthrough we see, this is primarily, there is a database. I believe you know the Milken Institute well, and it has a very good database. The best I've seen, actually, of the clinical trials that are underway. But I think in the end, we're going to be depending, and maybe this is not a bad thing, for the competitive nature of pharma to work with outstanding clinical investigators in academia to find the best drugs. I'm hopeful we'll have some very good data literally within 2 months that will tell us a lot about the current drugs that are being tested. I will say one other thing. If we had a breakthrough drug, a real breakthrough drug, I think we would know by now, because a breakthrough drug in a clinical trial, if it was really showing effect, the code would have been broken and we would have known that drug. That hasn't happened. So I'm hoping that that we will have a drug that will at least be reasonably effective in cutting down severity, like Tamiflu does for flu. But I think on that, Jim, which is it's going to initially be rather quick, and I think pharma is going to drive that process.
We're going to turn to Dr. Lee to discuss his current work on modeling in the response to the epidemic in just a second. But before we do, I wonder if you could just take another minute. You mentioned the numbers, how rapidly they were rising. I think I saw in a news report today the total now in just this short time in U.S. fatalities now are just about or have exceeded the total fatalities in the Vietnam War from the U.S. side.
Right.
The sustaining public attention, of course, is always an issue, but we're in a new era now, and I'm wondering if you could reflect on what the value and limitations of modeling and their use have been in previous epidemics. Has it been used well? Has it been used inadequately? Did they ever hit the mark?
Well, I should be careful since there's going to be a speaker who's a modeler following me. But what I would say, certainly in the case of AIDS, the models were, in terms of total number, they were usually much greater than the problem. Not that the problem isn't severe, but they were the projections were much worse than what it turned out to be. I think that is because, as probably we'll hear, the modeler puts in certain assumptions and gets out results from those assumptions. Where I think modeling was helpful to us was in modeling probably more helpful, was in modeling the impact of specific interventions. If you did this versus that, if you did these 2 versus these 3 interventions, what did you get for that? At what cost? I think in that sense, I found the modeling quite helpful in the case of HIV. And in fact, was very important for particularly because initially countries, it wasn't a one-size-fit-all because there were some countries with low prevalence of HIV and some countries with high prevalence of HIV. And the interventions, while they overlapped, in total were quite different. So I think there the modeling was very helpful. In just picking a number and just getting us to a number of how many cases and deaths, so many assumptions go into that sometimes. I think it's difficult to be as accurate and as helpful.
So thanks, Mike. I hope you're going to stick around for some cross-cutting questions at the end, and you'll have an opportunity in just a few minutes to put a question to Dr. Lee, who's following you. And it's just my pleasure to introduce Dr. Bruce Lee. Bruce is a professor of health policy and management here at the CUNY School of Public Health and Public Policy. He's a physician researcher. He's the executive director of the Center for Public Health Informatics and Computational Operations Research, and has been, if he looks a little tired or a little ragged, it's because he's been burning the midnight oil these last weeks and months with his current work on modeling the COVID epidemic. So without further ado, Bruce, welcome.
All right, thanks, Jim. Well, you gave me an excuse to look tired. Normally, I don't have that same excuse, but thanks for the introduction. And Michael, thanks for the lead-in, because I think your comments were very important, because one of the things I'm going to cover is, what are the strengths and weaknesses of modeling, and how should it be used and how should it not be used? And one of the things that we're seeing a little too much of is this crystal ball fortune telling, where we're saying, okay, these are the exact numbers. And I'll go into detail in a second, but that's really not the strength of modeling, and that's not really the purpose of modeling. So let me try to share my screen here, because I have some slides. And so I'm assuming I'm just hitting this right here. So can everyone see the screen, the slides?
Yeah.
Correct? Okay. And so I'll be covering, COVID-19 coronavirus pandemic, the use, misuse, and potential of information and models. So basically, oops, how do I advance here? Okay. So, the COVID-19 coronavirus pandemic was a real opportunity for information models and technology to really drive the strategy and response to the pandemic. So these are a couple articles that our team authored back in 2010, right after the 2009 H1N1 pandemic. So during the H1N1 pandemic, our team was actually embedded in Health and Human Services to assist with the national response. So we provide a lot of the modeling support to the CDC, Homeland Security, as well as HHS, BARDA, ASPR, et cetera. And we helped address questions such as, should schools be closed, or should social distancing occur, as early as April 2009? And of course, the answer then was no. And what to do in terms of the distribution of vaccines, what the impact might be, whether we would have a third wave, how to prevent that, whether there was enough capacity in terms of ventilators and hospital beds, et cetera, during 2009. And as we detailed, we felt that modeling helped with decision-making here and there, but there was also situations where there was a lot of room for improvement. So we felt that there's ways that modeling could have been better used. There was examples back in 2009 when people were tossing out early projections of what the pandemic would look like. And of course, as we know, the virus turned out to be not as virulent, or turned out to be a significant proportion of the population that was exposed previously to H1N1, therefore was immune. So that changed the projections. So we caution against using as a crystal ball and saying, okay, this is the number of people that are going to die, this is the number of cases that are going to occur, and emphasize that modeling had its strengths in terms of being able to better understand the mechanisms of what's going on, being able to understand what would happen under different types of scenarios, and bringing together people so that there can be coordination. And so we basically had a ramp in which we could have launched from 2009 through the Zika epidemic, which we helped address as well, and the Ebola outbreaks, the Zika outbreaks and the Ebola outbreaks, to really pull things together to help information and modeling and technology really assist the response to a subsequent pandemic. So for example, one of the lessons learned from our modeling is we demonstrated the value of protecting low-income and disadvantaged communities, because if you think about it, we're all connected. So if you actually protect low-income communities throughout the United States and throughout the world, you're actually protecting all of us, because many times you can have a virus spreading quite significantly. You have a lack of a healthcare response. These are pockets that can further propagate the virus. So even if you were completely utilitarian, and even if you didn't care about equity and things like that, you have a personal incentive to making sure that these communities are protected, because again, we're all connected. So these are examples of lessons that we learned from the 2009 pandemic. And then when fast forward, you have a situation in 2015 and 2017, these are articles that I wrote in Forbes, where 2017, Bill Gates, along with many other people, were warning that we're going to have a pandemic. It wasn't a matter of if, it was a matter of when. So we better be prepared. So those within the community were not surprised when this occurred. And also, back in, this is an article that I wrote early January, talking about this mysterious pneumonia that was appearing. And I mentioned that, if this is a novel virus, this could have outbreak, epidemic, or even pandemic potential. So people within the community were concerned about this. So we had a significant on-ramp to really get prepared to move things forward. So what happened instead? Well, we're facing what has been described as an infodemic, and I'm adding the word MIS in front of infodemic. So we're having situations where all kinds of information is floating around. We know that one of the things that has changed between 2009 and now is that information can get out a lot quicker and it can circulate a lot faster, even faster than a virus. So we're seeing situations such as, these conspiracy theories, such as, 5G networks are somehow causing COVID-19, or that Bill Gates was responsible for releasing the virus. The list goes on, and there's so much misinformation going out there. And these are sort of the more severe or out there things that are going around, but even more subtle misinformation is spreading quite rapidly in terms of what the potential treatments might be, or what's the value of social distancing, or why we're doing that. So it's really throwing a wrench into what the response should be, because as Michael mentioned, the response needs to be coordinated. We need to have a global strategy because this is a global threat. So moving forward, we also have situations where different people are wading into the waters and making statements. So I covered an example of Dr. Phil making the statement about coronavirus and saying that we shouldn't have done social distancing in the first place because there's 360,000 deaths a year from swimming pools. If you look at that number's off by an order of 100. So you can't imagine swimming pools killing 360,000 people. And also, to really draw the correlation suggests that somehow swimming pools are infectious, which, it might have microbes inside it, but the actual swimming pools are not jumping out there and trying to attack you. So we're really faced with this situation where there's this infodemic. And part of this is also, there's been a number of models that have been advanced. So they come with the label model. And the challenge is the term model is very vague and broad. So, it can range from, I take out a napkin and I put together an equation, I can call that a model, to things which are, more sophisticated and advanced. So saying model is almost like saying clinical study or epidemiological study. If I say, I have a clinical study here, your first question is, well, what kind of clinical study, or what are you actually doing with it? What are the details? Give me a better sense of what do you mean by clinical study. So all models are not the same. So you really need to understand and address the details, what's under the hood with each. So for example, I mentioned, one type of model is, simple equations. So let's take an example of a field that has really been transformed by models, which is meteorology and weather. So if you think back, way back, before you had any types of computational models, how would people really determine what the weather is and what it might be like and what are the different scenarios, well, you really were left with sort of looking at the stars, the moon, and the cows and seeing what they're doing and trying to predict what's going on. And at best, you could predict what's going on maybe later today or maybe tomorrow, et cetera. So, but now we have sophisticated computer models. But if we're talking about simple equations, imagine if a weather person or meteorologist would get up and say, okay, the amount of rain equals the number of clouds times the darkness of the clouds. And that's how I'm going to predict the amount of rain. Well, that's a very simple equation. And that's just some of the quote unquote models that are being advanced out there. They're doing back of the envelope calculations. And they're saying, oh, okay, this is what I think is going to happen because I've done some very quick calculations. So that could be helpful when you're like on the run and you really don't have any time and you need to quickly do something and really just say, okay, I came up with a very quick number. So there is value of that, but people have to clearly identify that that's what they're doing rather than, suggest that this is a very sophisticated or advanced model. A second type of model are statistical models, statistical correlation models. So again, if you were to use these in meteorology, you would simply say, okay, how much rain occurred on April 24th in previous years under similar conditions? So I draw a correlation and I put in different types of variables and I determine from that the relationship between April 24th and rain. So, we're seeing some of those and, they can be helpful because they're essentially top-down approaches. So you look at data and then you look for what the patterns are in the data. And then you say, okay, we think this happened. These are the correlations. And then this is what's occurring here. And then, okay, well, maybe we can project over there possibly. But this is most helpful for discovery when you don't really know the actual mechanisms of what's going on. And you just want a broad overview and you have a bunch of data and you want to determine what might be happening. So a lot of the models out there that you see for COVID-19 coronavirus are statistical models where they're saying, okay, we've drawn correlations in one place, let's draw it elsewhere. So we have to keep in mind, correlation does not imply causation, and that these models can be broad brush. They can overlook details, they can overlook the complexity of what's actually going on. So we have to take with a grain of salt. They can be valuable for discovery or some quick general insights, but they do have their drawbacks as well. And as an example, here's a classic graph we always show when we talk about correlations overlooking complexity. Well, if you were to graph the number of pirates on the x-axis here and the global average temperature, you would see this type of correlation. So that would suggest that you should try to somehow change the number of pirates and boost the number of pirates so that we can decrease the global temperature? Certainly not. But this is an example of how you have to be cautious when you draw some of these correlations. The third type of model are the quote unquote mechanistic models. And these are models that try to recreate all of the processes involved in something. So essentially, this is what you see when you see these weather maps. These weather maps are actually mechanistic models. So what they do is they try to take different types of disparate information and data, such as barometric pressure, what the winds are doing, temperature, terrain, et cetera, and then recreate these different weather patterns. So they're actually recreating the processes of what's going on. And so that's why these are mechanistic models. And these are the basis of what you see on TV whenever you see those different types of weather maps. This was a significant advance because when you put in the mechanisms, then you can get a better sense, okay, when might the hurricanes occur? What might their paths be? What you should do in terms of evacuation and those type of things. So they're not perfect, but we're getting a better sense of what to do with these types of weather maps. So these are so-called bottoms-up approaches where you're actually trying to recreate the mechanisms and processes of what's going on. You're trying to rebuild the systems. So there are models out there that are more mechanistic models. And we're really at a key inflection point because previously, like years ago, one of the reasons why there weren't as many mechanistic models is people didn't really know the mechanisms. But now we have a lot more information. We have a lot of information from basic science. We have a lot of information from data, AI, mobile devices, all those different types of things. So we're in much better position to put together mechanistic models to really simulate what's actually going on. Now, keep in mind, even if you see a mechanistic model, you have to understand that there are many different types of mechanistic models. So we have to remember everything's in a complex system. We're all connected. You know, there's a lot of interactions that are going on. We have social, political, environmental, economic systems around us that affect us and that we affect. You know, and everything throughout the entire world or universe is part of a complex system. So, and if you don't consider these complex systems or to consider these systems, you might have band-aids rather than solutions, unsustainable solutions. You might miss secondary and tertiary effects. You might have unintended consequences. So you do something, especially if it's not coordinated, you might actually have worse effects, and you can expend tremendous time, effort, and resources from trial and error. And we've seen a lot of that during this pandemic. So a big question is when you see a model, you have to ask yourself, and if it's a mechanistic model trying to represent all the mechanisms, you have to ask yourself, how much of the system does it actually represent? Or does it really actually focus on one part of the system? So you're seeing, for instance, some of these epidemiological models, like, you know, one's out of Imperial and one's out of University of Florida, University of Washington, and they're like epidemic models. So they're really focusing on some of the properties of the virus and representing the spread of the virus. So that's their focus, because that's the strength, that's the area of expertise. But they don't necessarily represent the clinical course of those who are infected, you know, the population and some of the specific interactions, economics, healthcare system, and resources, et cetera. And that's fine. We need these mechanistic models to focus on different aspects of the pandemic to get a better sense of things. We run into trouble when you have a mechanistic model that's focusing on one thing, and then broad projections are made based on focusing on one thing, because you don't know really the reverberations throughout the entire complex system. So again, you have to understand the tool, and you have to understand the limits of what it can do and what it can do well and what it can't do well. So, you know, one of the challenges is you do need kind of larger models to really pull things together, because we're running the situation where disciplines can be very siloed. So you have biological experts, you have experts who really understand the spread of a pathogen. On the other hand, you might have experts who really understand aspects of the healthcare system, or experts who are clinical experts, et cetera. And they can focus on one part of the issue or the problem. And they can be helpful for specific aspects of the system, but they can't overlook other parts. And then so you see, you do have this divide, this hang-in between that and the fact that problems are not discipline specific. Problems can cross scales. So basically a problem can affect the, you know, the microbe level, and it can affect population level and larger level, economic level, et cetera. And they can involve entire systems. So how do we pull things together? Well, we need systems models. We need models to actually make these connections between the different aspects of the system and try to give us a better sense of, you know, how do these then translate and more broadly. So that's one of the things that, you know, we've been in the systems modeling or system science field for a number of years. And what we've endeavored is to try to cross disciplines and try to pull different things together. It takes time, of course, but, you know, we feel that there's also need to do that because, you know, again, funding, departments, disciplines, they're all very siloed. So, you know, how do you pull everything together to make it most useful for decision makers? So let me give you an example of some of our initial modeling efforts when it comes to COVID coronavirus. You know, we had a head start because we've been modeling the flu for many years, like 15 years or so. But I also want to emphasize, as all of you know, the flu is not the same as this coronavirus. They're very different. So there's some similarities in the sense they're both respiratory viruses, but there are a lot of very different things. So we've had to adjust a lot of our models. So this is a very, very bare bones graphic just to give you an idea of what we're looking at. So we represent the properties, the biological properties of the virus. We have entire US population, simulated population. And then we will introduce the virus in different ways to this population. And this population interacts and with each other and can spread the virus. And then so we will represent the spread of the virus throughout the US population. And each person, when he or she gets infected by the virus, he or she can then travel down a different path of possibilities. So maybe asymptomatic. So basically nothing really happens except the person may spread to others. That person may have mild symptoms. That person may have more severe symptoms, then require admission to a hospital and it require ventilator use, you know, all these different things. So we have a whole chain of different possibilities that might happen. And we've been using data to parameterize, you know, different probabilities. And then what we'll do, what we've done is we've developed representations of hospitals and clinics and things like that, and we'll track the costs that occur. So one of the initial studies that we've done was just published in Health Affairs yesterday. And it basically, we ran this model on many different circumstances and try to determine what are the potential direct medical costs that may be associated with the pandemic. So let me give you some examples. So this is from simulation runs showing the range, the median and the range of different costs for different types of cases and different age groups, et cetera. So again, the population that we developed within our model is really, down to the different types of demographics. So each person has a different gender, age, et cetera. And so here are some of the numbers. Now, one of the striking things is if you look at the median cost of a single symptomatic infection, that's over $3,000, and with that range, or of uncertainty, I'm sorry, actually some of those numbers are that 4 out there is a mistake. But I want to emphasize that this cost is multiples more than the flu, and it's more than pertussis and other types of diseases. So this is a more costly disease on average, and this is all symptomatic infections. We do know that a large percentage of people are either asymptomatic or have mild symptoms. So then you've got hospitalized cases, which are a lot more. So this really emphasizes the fact that this is a different disease, not just from its biological properties and clinical properties, but economically, it's a very different disease. And one of the reasons why we wanted to do this is there's so much talk about the cost of social distancing and how we need to reopen things because of the economic cost. We've got to think about the other side of the equation. We've got to think about things such as the healthcare costs, the direct medical costs. If you allow the virus to spread more and more, what's happening is you're going to incur a lot more costs to the economy. And so this graph here shows essentially the direct medical costs of the acute COVID-19, not the sequelae, just the acute, and the billions of dollars, not just the billions, but the hundreds of billions of dollars that it's going to cost in terms of direct medical costs. If you increase, the x-axis is increasing the percentage of the population that gets infected. And we actually tried to be conservative with this because, we wanted to just stick to really direct medical costs, and there are many ways where we try to stay conservative. But this is the median and then the range under different scenarios of the cost, and you can see it goes well into the hundreds of billions. And then if you add post-acute costs, these are like from the sequelae of illness, like for instance, someone who may have ARDS or have lung damage, they're going to have problems going forward. Or if someone had sepsis and had organ end stage organ damage, so if you add these, it further boosts up the cost. So you can see in some scenarios, it's getting up to the thousands of billions. So we have to keep in mind, and one of the things that Michael mentioned is don't hang your hat on very, very specific numbers. Don't say, okay, we know exactly this to this precision, this number is going to occur. We more want to think instead of the orders of magnitude and the different types of things that drive some of these numbers and what will change these numbers. For instance, the percentage of the U.S. population that gets infected is a significant driver. So if you're going to rely on a herd immunity strategy where you allow people to be infected, it's going to cost you. So those are some quick examples from our study. I do want to acknowledge the support that we've received. We received a generous support from the CUNY Graduate School of Public Health funding for this. So I wanted to thank our dean for being for having foresight in supporting our modeling efforts. And we've also had support from AHRQ and IGMS and NICHD. So with that, I just want to give a quick summary of what I mentioned. So there's lots of information being spread right now. That's good information and misinformation. And trouble is there's the problem with the drowning out. You're drowned out by a lot of misinformation. So I hear all the time where people say, I don't know what to believe. And that's a problem. Secondly, various models have been emerging, but we have to keep in mind that the model is a very vague and broad term, like a clinical study or an epi study. So we really need to better understand what models actually are and how to separate them and how to distinguish them. We have to distinguish them between the what are calculations, simple calculations versus statistical models versus mechanistic models. And it's really important to understand, someone has to tell you what part of the system am I really focusing on and what are parts of the system am I neglecting? Because if it's focused on a particular part of the system, great, but there are limitations. So there is tremendous potential for models and information. And one of the key things is to really, as alluded to previously, it can help us really strategize, understand the value of different interventions and policies and things like that. It can help understand the mechanisms that are occurring and the key drivers. So we can't use these as crystal balls and someone like walks in and says, I think this is going to occur, and then walks right out and doesn't really explain everything behind it. Because then we're misusing models, and that's really not the thing to do. The other thing is models can really bring people together and say, okay, what are you looking at? How do we then coordinate among the different states or the different locations or the different countries? Because we're really going to need to do that. We're going to really need to coordinate among different countries. And this is a terrible time to be uncoordinated. It's basically like going out onto the football field, onto the pitch, and saying, I'm not going to cooperate with my teammates, and I don't have a whole view of things because I don't have a model that really kind of pulls things together. So I can only see one part of the field, I can only see one opponent, and I'm going to try to win this game. That is a losing strategy. So basically, we need information, we need models, we need technology to really find ways to support decision making, not just within the United States, but globally, because this is a global problem. So the potential is far from reached for modeling, and there's a lot of opportunity. So with that, happy to address any questions or comments and thoughts. And I also wanted to just point out our Vicor team. They've been working day and night on our modeling work, especially Sarah Barsh and Marie Ferguson have really been leading these efforts, and Cheryl as well. So thanks to all of them.
So Bruce, thank you. I know we have more questions, unfortunately, than we have time. And I know Mike had a question. I had a couple of questions on the would have been, could have been, should have been, and what we should have done between 2009. But perhaps we can save those for the crosscut, which will be coming up in just a little bit more. But first, before we turn to Dr. Cravero, who will talk about the global response, could you briefly just give a shout out, if you will, in terms of what modeling should be telling us, or what modeling is telling us, or could be telling us about the parameters around the depth of the global humanitarian crisis that we may be facing?
Mm-hmm. So models certainly can do things like, first of all, alert people to the potential impact, and help quantify the impact, but also help coordinate strategies and policies. So we do know from years of modeling what works and what doesn't work, like social distance. The whole reason why we're doing social distancing is models have clearly shown unequivocally that that's the way to go if you don't have a vaccine or a specific treatment, and the value of things such as test, trace, isolate, the value of testing, and basically understanding everything that's going on. So we do need that coordination, and we need a better understanding of how to coordinate the response in each of the countries around the world, and also help people understand how that then comes back and affects higher income countries. Because many times, if people are thinking selfishly and they think, okay, well, we don't have to worry about it as long as it's not immediately in our neighborhood or backyard, that's dangerous, because we are all interconnected. And what happens in other countries will affect us. This pandemic has to show that, and models can really show that, how to coordinate all of these different things.
Okay, thank you. Mike, did you want to ask your question now, or do you want to hold for the crosscuts? Up to you.
We'll just ask very quickly, Bruce. I think it's a nice presentation. What has struck me so far in this pandemic has been the impact, good or bad modeling, we'll leave that aside, has had on the media and on political leaders. I think, but again, I've seen the media just loves numbers, no matter how numbing they are. They love numbers. They love showing these graphs, and I think it's been very striking to me here. And secondly, I think you had a president who claimed he only extended the we'll just call it the lockdown in this country because of some model that he saw. That's what he said. And you saw Cuomo, who really used modeling, I thought, quite cleverly to decide on the number of beds that he needed. I mean, he didn't need them, but to be able to plan so quickly, he made every hospital in New York City go from, increase their load by 50% overnight.
Mm-hmm.
So it is striking to me that sometimes models, good or bad, can have an important impact on political leaders, often through the media. I just wanted to add that, and it's just something to think about, the responsibility that modelers have at times because of their potential impact.
Mm-hmm. Absolutely. I think it's really important. The modeling community is to blame too, like in the past, for not being able to communicate what models should be doing and what people should do with the results and what their models are actually doing. So I think communications is extremely important and helping everyone understand better what modeling should and shouldn't be doing.
Great, thank you. We're always trying to figure out the difference between using a model for our planning or our alternatives versus a Vegas point spread in terms of how we can, what we're going to bet on and how we're going to demonstrate that we did better than was projected. So with that, let's talk about what we're not talking too much about. I think, come back to Mike's earlier point, we've been mostly focused on our immediate, as we all are. There are kids in the background. There are, the gathering is on Zoom. We're not interacting as we normally do, and we're not looking at the world as we often do. And so it's my pleasure to introduce our next speaker to kind of force our look out a little bit. Dr. Kathleen Cravero is of New York and returned to New York. She's with partially. Has one foot in Sweden and the other foot here now after a distinguished international career, which is continuing with us. She's a colleague of Bruce and mine at the Department of Health Policy and Management in the Center for Immigrant, Refugee, and Global Health here at CUNY. She was a colleague of Mike Merson, as Mike was orchestrating the global response and the development of UNAIDS. She was there working with him. Before and after that, a distinguished career at UNICEF. She also served as the Deputy Director of UNAIDS. She was Assistant Secretary General of the United Nations, looking after reconstruction, post-humanitarian crises, and has then spent a decade as the president of the Oak Foundation in Geneva before joining us in CUNY. So without further ado, Kathleen, if you could point our directions at what we don't know is going on in the global arena.
Okay, thanks. Thanks very much, Jim. I think my remarks, which will be short, will go back to really where Mike left off when he said that we very much needed a global, some sort of global response and global perspective on COVID-19. And actually there is one that exists that I think what I'll spend the next 10 minutes talking about is just what its strengths and weaknesses are, which I think dovetails nicely with some of what Mike said. On the 9th of April, the United Nations launched something called the Global Humanitarian Response Plan to COVID-19. It was launched by the Secretary General. It is a plan asking for $2 billion over the next 9 months. It covers 64 countries, but it's clear that that number of countries is evolving as the pandemic evolves. It's based on humanitarian principles. It's a humanitarian plan, which is very important to realize. It aligns with the WHO strategic response. It includes the entire UN system and the main UN partners. But as a humanitarian plan, it's not a platform for research. It's not a platform for knowledge sharing. It basically, in its strictest sense, is the life-saving measures that are anticipated for a response to COVID-19 in low-income countries over the next 9 months. It's positioned in addition to all the existing humanitarian plans, and you might know that at any given time there's at least 40 plans out there for armed conflict and post-natural disasters. This is positioned as in addition, and the Secretary General makes clear that the rationale is that the world is only as strong as its weakest health system, which is also similar to something Mike said at the end of his comments. This plan does reflect lessons learned during Ebola and SARS and earlier pandemics. It came together, as Mike said, what took the equivalent of 20 years, or in some other pandemics have taken a year or 18 months to come up with a plan. This was come up with in about 4 weeks. And it does bring everything together. The UN system is aligned. There are 3 objectives to this plan. One is to tackle the health emergency, which is basically to contain the virus or contain the spread. The second is to address the social and economic responses, or otherwise you could describe it as a way to decrease or slow down the deterioration of human assets. Everything from social cohesion to livelihoods to the protection of human rights. And the third objective is to recover better by building more inclusive, equal societies in line with the Sustainable Development Goals. So contain the spread, slow down the deterioration of human assets, and recover better. Build a fairer, better world for the vulnerable groups and the inequalities this pandemic is exposing. So, sounds good, and the fact that the UN would launch a humanitarian plan makes sense in the sense that at the speed at which the pandemic is spreading and the nightmarish scenarios in developing countries, it's right to go with the humanitarian plan first with all its weaknesses. But I just wanted to, in line with some of the challenges that both Mike and Bruce have raised, I just want to go over a couple of the real challenges that are posed to the international system by this particular crisis that we're trying to develop a global humanitarian plan for. The first is 99% of humanitarian plans are about one country that's either in civil war or imploding in some way, or it's about something that's going on among 2 or 3 countries, or maybe at a stretch, it's about a region. This humanitarian plan is 64 countries and they're adding every week. So it's basically about the entire world, and it's about a crisis with very diverse and as yet unknown impacts on many of the countries. The second is that one of the principles is that humanitarian plans will focus on life-saving measures. And you can see from the 3 objectives I cited, only one of those, contain the spread, has really life-saving measures in it. The others go way beyond humanitarian. This is always dangerous because humanitarians do humanitarian work well. These plans do not tend to cover beyond humanitarian work well, so we're on dangerous ground here. The third is that there are real dangers for humanitarian workers. There are always dangers for humanitarian workers. And it's not that you always know where the enemy is, but you have an idea of where the enemy is, and you have an idea about how the enemy or the dangerous force is going to react. In this particular crisis, it's kind of an invisible force, and humanitarian workers may come face to face with this danger and be affected by this danger and not even know it for 2 weeks. So the complexities of the dangers facing staff working in this crisis are just unprecedented. The fourth is that most humanitarian emergencies, that the heart of humanitarian emergencies are logistic operations. The flow of people, which do the technical and program work, and the flow of supplies and goods, which keep people alive. We can't even begin to say what the disruptions in supplies and logistics are going to be over the next 9 months or 12 months, and the impact they're going to have on the delivery of any services, humanitarian or otherwise. The fifth, and this is really important for humanitarians, and I think we're going to really see humanitarians start to unravel around this difficulty, which is there's going to be really complex and serious tensions between tackling the health emergency objective, containing the spread, and addressing the social impact and economic response objective, specifically protecting individual freedoms and human rights. Now, all humanitarian plans, all humanitarian crises have an interface and a balance between what humanitarian interventions require and protecting human rights. But always before, the humanitarians have always been absolutely in the protecting human rights camp, and the limiting individual freedoms has always been the oppressive government or the non-state actor that's causing violence. In this particular crisis, there are going to be cases or situations where humanitarians are going to be promoting the limitation of individual freedoms in order to contain the spread of the virus. And there's two dangers to that. One is you playing into the hands of oppressive regimes who think that's great. And secondly, these temporary measures could perhaps never be lifted. And we're already seeing that with surveillance, and we've experienced that before. The seventh is that donor funding at its best is never logical and often not helpful. And their donors are picking what they want to fund, and it's not necessarily what's needed. In this particular crisis, not only will donors be doing that, but there may be no money for low-income countries, or much less than we have in a normal emergency, because countries, all the things that both Bruce and Mike mentioned, but countries are going to be needing their money or perceiving to be needing it for themselves. And the seventh danger is that the potential impact of this emergency on other emergencies, the impact of the pandemic on weak regimes and fragile states, on ongoing conflicts, on national security, on food security. I mean, in some cases, one of the biggest impacts of this pandemic could be starvation. And in some cases, that might lead to food riots, increased violence as people are fighting over getting supplies, everything from medical supplies to, frankly, water, which has already become one of the new causes of conflict in the global South. So for all these reasons, this is a highly complex and unprecedented humanitarian emergency. In addition, and I think, as I said, we have learned from the mistakes, and this does represent an improvement in the way that it's designed, this humanitarian plan, but we're likely to repeat some of the mistakes we've made before because of the nature and the complexity of this crisis. One, the whole idea, we don't do well at connecting the life-saving measures to the longer term measures. And that's going to be absolutely vital here, because it's one thing to keep people alive. It's quite another thing to build the health systems, to address the inequalities, to put the political regimes back together, et cetera, or governance back together. And often there's a disconnect, and we're going to have to be concerned about those. The second is the temptation to follow the money, because there's going to be so little of it. The third is the plethora of guidelines that technical agencies are now churning out. Children is one example. There's at least 15 sets of guidelines on what COVID-19 will do to children. And there doesn't seem to be the adequate coordination on those. A disconnect between global coordination and country action. You're going to see concerts and all sorts of convenings, virtual convenings, and a big hoopla at the global level about what needs to be done. forgetting that, you know, this is a pyramid that it's big at the global level, and then it goes down to countries, and there's very few people doing the work that everyone's coming up with, or all the ideas that everyone has. And my last point is that this idea of recovering better is also connected to what comes after humanitarian. And the panic, the lack of money is going to make the idea of recovering better difficult. And there's already a raging debate about whether recovering better or not. I just say it's way too early to say, but those who feel that we may already be missing the boat on recovering better talk about, you know, in Hungary, you see, you know, in the authoritarian regimes are becoming more authoritarian. The science deniers are becoming even more accentuated in denying science. That the inequalities are just growing. There doesn't seem to be any particular thing going on to bring them together. So these are the mistakes that might be made. So just to say that there is a global response underway, it's going to meet a lot of problems, and it represents only the tip of the iceberg. That's what's needed. So I'll stop there.
Kathleen, thank you. Before we have a little bit of time left for our little crosscut panel. I'm looking over my my shoulder to see if I'm getting a list of broader participant questions from Mohit. But as we move to that, Kathleen, no one loves to criticize the multilateral system in the UN more than the US, you know, which is a little unusual since the US was the principal driver of establishing it, and actually the Allies in the Second World War referred to themselves as the United Nations. So there's some kind of unusual elements that, but and I think it's often been said that what's obvious, what's wrong with the UN system is obvious from a mile, but when you get up close, there are some intrinsic things that are really irreplaceable and essential in something like this. For someone like yourself who's made your career there, what would you consider those essential elements? What is it, if we didn't have a UN right now to help us with this epidemic, that we'd have to invent in order to help respond to it?
You know, I think that Mike was very articulate about that in talking with WHO, and I think you can look at that across the system. I think the UN, for whatever its weaknesses are, has established a platform, and in many countries, relationships of trust and authority with national governments, and also in, you know, a demonstrated ability and commitment to building national capacity to respond to all sorts of problems, including a pandemic. But I just think right now, and in this particular crisis, it really might be dealing with half a deck, you know, on what it can do in terms of resources and room to maneuver. But yes, I think absolutely, if we didn't have something like the UN, we would have to invent it. What the UN is doing right now is absolutely appropriate for the UN to be doing, and it's doing it quickly. I think suggesting to do the right things in this humanitarian plan. How we're going to build a mechanism that Mike talked about that can do the longer term interventions is not clear, but the only avenue to do that, I would suggest, is the UN. I mean, we don't have any time to create anything else. It's through multilateral mechanisms that already exist.
Thank you, Kathleen. I want to bring Dean El-Mohandes in to help us kind of connect this back to our global city in New York. I want to also welcome the panelists to ask in our little crosscut section here to question each other. Just to provoke a little bit, I think several of the people, at least on the screen, can remember when you had to go to a phonetics class to learn how to articulate billions instead of millions when you talked about the response to, say, the AIDS epidemic, and getting people, no, really, there's a B there. There's a B in front of that word. And now we're speaking in terms of trillions in terms of what's going on. And I wonder if to what extent in each of your minds is like, boy, how much of this could we have spent in advance of all of this and saved a lot of this? What short-sightedness? Why didn't we invest in the local public health capacity? Why haven't we invested more in the international surveillance capacity? And I know Bruce has worked on that from the modeling standpoint since 2009. Michael, in his academic career, has been spending, the last decades trying to figure out how to build the capacities in this country that were needed 20 years ago when other things happened. So that's certainly an issue for us to deal with. Also, what's the organizational impact of this afterwards? Kathleen, your work in terms of recovery. Organizations just don't bounce back. They're damaged in the course of a humanitarian emergency. So this building back better, what is that all about? So that's just I'm looking for our panelists to kind of go after each other a little bit for some clarification. And then I'm looking for Ayman to help connect us back to our city, and I'll be quiet and let you do that.
Sure. I'm very ready to jump in. First of all, to express appreciation that in moments such as this, we get so preoccupied with the here and now, with the urgency that we need global thinkers that can take us out of the immediacy to a second level of urgency. And I think that's what our speakers have been able to do today. There are people in the trenches, but there are people that are strategizing to end the war. And I think emphasizing the role of the United Nations is very encouraging, but the United Nations itself needs to challenge itself to become perhaps more nimble, more effective, and more transformative of itself, and hopefully in collaboration with countries around the world. New York seems to be on a slow recovery slope. The number of admissions is slowing down. The number of deaths is as well. And we are challenged now by thinking smart about what the next phase is going to look like. I think over-optimism is our worst enemy, and paranoia is just as an effective enemy at this point. My personal preoccupation is going to be about science and education, and how this epidemic is going to impact on science and education globally. But I have to think of our institutions in terms of public institutions that support science and support education, that they are not victims that will be suffering from reduction of resources or preoccupations of society with other immediate needs that will undermine their commitment to science and education. I think our students in a public institution require a lot of support during this moment. There is an intersectionality of challenges that face them, life reality, as well as modalities of learning, as well as opportunities to partake in training on the ground and in the field, all of which are things that we need to be thinking about. If I think about New York, in a couple of weeks from now, in these weekly grand rounds, in a couple of weeks from now, on May 8th, we will be sharing the results of a 10-week survey looking at New York and the impact of the COVID epidemic on New York. But next week, we will be talking more about boots on the ground with people representing India, Taiwan, and Africa, talking about successes as has been seen in Taiwan, as well as challenges now in India and some African countries. But I would like to hear from the speakers, our invited speakers today, as to their experiences in the area of training. There will be such a need for a workforce that never existed before. We saw that during the AIDS epidemic. of people going door to door, of people engaged in behavioral modification, in people engaged in surveillance that did not exist in many of these countries. And I hope very much that there is a focus on training of professionals, recruitment and support of these professionals that will be needed to engage that epidemic. And Mike, what are your thoughts on that? And Bruce, do we have modelers in terms of the army of professionals that need to be in the field in the near future?
Thanks, Simon. I know time is short. Let me say this to you. I've been in academia now 20 years, and I think we have an opportunity here that we must think about, those leading schools of public health in particular. I think there's going to be a great interest in public health, particularly global health. In my lifetime, I've never seen it where 80% of the population even knows what the term global health means. And I think we've got to build on this enthusiasm. There will be some reticence initially, maybe for people to come to New York, but that will be brief. Many people, I think, will be excited to come to New York. And I think that how New York can come together academically would be a really interesting challenge. I think the workforce right now we need, as you know, and I hope Mike, Bloomberg makes use of the enormous manpower that exists right now to help with contact tracing. I don't think he needs to go to Baltimore for that. But I do think that we have a short-term opportunity right now in New York. But then I think we have a larger opportunity to think through curriculum and to capture the enthusiasm and excitement that now exists in our population around global health. Not just, of course, we don't want it only to be on pandemics, okay? We want it in a broader context. But right now it's an entry point, as AIDS was an entry point. Look how many things happened, as Jim and Kathleen knows, in so many domains because of AIDS. And I don't even think we can begin to predict the changes that are going to take place in our lives, but certainly in the academic world and in the training world. So I've been impressed, one last thing, I've been impressed that the health workers here in New York have really not hesitated with enormous enthusiasm to tackle COVID. I'm not sure we could say that in the early days of AIDS. I think it's really impressed me, the without hesitation, the risks that healthcare workers took. And that you may remember in AIDS, it was not quite like that in the beginning. So I just want to say there is a silver lining in this. If I may say, Kathleen, I wish we had more time. So much of what you said reminds me of the discussions that you and I and others had around what to do about AIDS. And we couldn't come up with an answer, so we invented UNAIDS. And not to talk here about the pros and cons of that decision, but we are in a very similar boat. And I hope the best thinkers are going to really think about this now. And what can we and should we do? To me, it's a fascinating question that has again come up. Why we weren't prepared for it, that's the sad part. That is really the sad part, Jim. That we should have been able, to build on our many years, even just building on the experience with Ebola would have been helpful. Instead, we just forgot.
Thank you so much.
Stop.
We're coming to the end of a wonderful session. I need to remind our participants of our next session on May 1st. Join us for the next seminar, our virtual COVID-19 Grand Rounds. We will focus on the next wave and lessons learned on the global stage. Joining us will be Dean Changchuan Chan from Taipei, from Taiwan, Professor Wafa Al-Sadr from Colombia, Director of the ICAP program around the world, Rakesh Kumar, the Chief Advisor of the United Nations Development Program in India, and our own Senior Associate Dean, Ashish Joshi. Please join us on May 1st, and we promise to continue these seminars on a weekly basis until the end of this academic year. Again, thank you for your participation.
Thank you all. Thank you, Ivan.
Thank you.